Howdy, y'all. I'm Dr. Jeff Jarvis, and this is the Hemorrhage Control Protocol Review Module. This is another one of those protocols that combine several prior protocols into one place to simplify our protocols and get rid of a few extra pages. This should be pretty quick, so let's dive right in. At the basic level, this is where we authorize the normal procedures that are really common sense and covered in every EMT class. Obviously, direct pressure is the starting place. The key to direct pressure is it needs to cover both the area of bleeding and a little bit proximal to it, closer to the heart, as Rush would say.
Closer to the heart.
Now, it needs to be both firm, so put a lot of pressure on it, and persistent. Just poking obviously doesn't do it. Now, if direct pressure doesn't control the bleeding, then apply a tourniquet if the bleeding is on an extremity. Now, there are some things that are obvious, but I want to point them out anyway. The head, not an extremity, so please, no neck tourniquets. Those are bad. Death, occluding, strangulation, bad. Plus, neck tourniquets are kind of called ties. I have to wear them, and I'm pretty sure they should be banned by the Geneva Convention. No neck tourniquets. Now, we have a specific procedure video for tourniquet use, so I'm not going to discuss the hows of tourniquet use here. Suffice it to say, though, tourniquets only work if they're tight enough to occlude arterial flow, and that means pretty damn tight. If you've ever put one of these things on yourself, you'll know that tight enough to occlude arterial bleeding for any period of time is likely to hurt. If it's not hurting at all, and they're capable of feeling pain, then maybe it's not tight enough. Now, if direct pressure and tourniquets don't work, add wound packing with hemostatic agents, the stuff that helps promote clots. Now, I'd also like to talk about a couple of tips for special bleeding situations, specifically bleeding dialysis fistulas and varicose veins. Both are high-pressure bleeds and can be difficult to control. To help decrease the pressure of the bleed, stick the arm or the leg, if it's varicose veins, straight up in the air and get gravity on your side. The gravity thing alone is remarkably effective for varicose veins. The reason they're under high pressure is in the lower extremity, and all of this gravity pressure is pushing down on these veins, and the valves that normally help them from getting all bulgy are gone. They're stripped, so the veins get really big, and that means there's a lot of pressure there. Flip them upside down, lift it up in the air, and that helps decrease the pressure so that your direct pressure is more able to control the bleeding. Now, with dialysis fistulas, avoid tourniquets if you can. So what we want to do there is grab some hemostatic gauze and put it on with the direct pressure and elevation, and only if that doesn't work after about 10 minutes of tight and persistent pressure, then go for tourniquets. Now, you'll notice I said tourniquets as in two. Put one on right up above the fistula and another right under the fistula. We don't want to put it directly on the fistula. Now, there are also some tricks of the trade out there roaming around using bottle caps. Now, I'm not talking about the ones, the metal ones that have the little teethy things. Don't put the little teethy things into the dialysis fistula. That's bad. The vascular surgeon's not going to be happy, and I promise you I'll hear about it. No, we're talking about the little things like on the Diet Coke, the little plastic ones that don't have the sharp teethies. There are some videos out there, some papers out there. Put the little thing directly over the hole and put pressure on. Sometimes that can help. These are all fine and dandy, and they seem to work well, but they're not actually part of the protocol itself because I'm not going to specifically endorse it because I don't have great evidence that it works. There's no evidence that it's really causing harm, so they're fine if you want to give it a try. Now, also at the BLS level, if you think the bleeding is from a pelvic fracture, then apply a pelvic binder and be sure to do it according to the pelvic binder procedure. The biggest thing that we do wrong with pelvic binders is we turn them into abdominal binders. Really needs to be a lot lower than you think it does, so please watch the video. Now, one thing we're learning about pelvic fractures that's kind of helpful here is they don't seem to bleed as much as we thought they did before. So what do we do with this little piece of information? Well, basically, if you think the bleeding is coming from the pelvis only, keep looking. Make sure you're not missing something. Look in other places. And the same thing, by the way, goes for isolated femur fractures. We used to think the entire blood volume could go in there, and it turns out probably not. So just make sure you're not missing other bleeding. All right, that's it for basic. Let's move on to the advanced level, and here we add some drugs. And by some, I mean mostly TXA. Now, as a review, tranexamic acid, TXA, helps to control bleeding by inhibiting the natural process of breaking down clots. I like to think of TXA as an anti-TPA, so let me explain that. TPA is the stuff in our bodies that's naturally occurring, and it acts to break down clots that we're always forming so that we're not walking around as one great big giant clot. That's good. Now, we in medicine, like I'm going to take credit for this, other people have figured out how to synthesize that and make a really concentrated dose. And the medical version of it is really the same thing, just more so. And that's the clot busting drug that we give to patients with acute ischemic strokes to increase clot lysis or breakdown and hopefully return function to the brain. So that's what TPA does. And if it breaks down clots, and TXA is the anti-TPA, that must mean that TXA inhibits clot breakdown, and that's exactly what it does. It doesn't promote clot formation, it just inhibits clot breakdown. So why is that distinction important? Well, because if TXA made clots, that might be good in acute bleeding, but it also might cause strokes and heart attacks and DVTs and PEs and bad things. Now, fortunately, the trials of TXA haven't shown increased clotting risk, which supports the no clot formation thing, just slowing down breakdown. All right, I know how much you want more pharmacology, but that's it for now. Let's just talk about how we give it and when. So when we're giving it by the IV or IO route, we're giving it for adults with traumatic, GI, OB, or tracheostomy-related hemorrhagic shock. I stress the hemorrhagic shock. Because the evidence is equivocal for its use in TBIs, we do not want to give it to isolated TBIs. But kind of like bleeding from the pelvis or femur, if you think that that is the only source of bleeding, please keep looking. So it's actually okay to give TXA in multisystem trauma, just not if you think it's an isolated TBI, meaning there's no bleeding anywhere else. So to be clear and hopefully to keep you from staying awake at night worrying about it, there isn't any evidence of harm in TBI patients. It's just not indicated, except for a small set that we're probably not going to be able to identify well. So try not to give it if you think it's just an isolated head bleed. But if it turns out you're thinking there was something else going on and you give it, probably no harm done. So I think you're all right doing that. Now, how do we give it? 2 grams slow bolus through the IV over a minute or so. And we do this for this indication only in adults. Turns out TXA can also be effective, though, when you use it topically. Now, the most studied version of this is for nosebleeds, but it's commonly done for bleeding gums or bleeding teeth that are broken up. And for those, just grab some cotton balls or 2x2s, saturate them in TXA, and then shove them wherever the bleeding is and put direct pressure just like you would normally. Let's talk a little bit more about nosebleeds, though, because even though we're just using a topical approach, there are some tricks to making it work better. First, remember the anatomy of the nose. The distal part, the part down here, this is all fleshy bit. pressure works well here. The proximal end, though, the part up here, that's bone. Pressure on bone doesn't do a damn thing to help control bleeding on the other side of the bone, which, when you think about it, makes sense. Now, fortunately, most nosebleeds are distal, things we call anterior bleeds, as opposed to the deeper posterior ones. That's really good because pressure can work to control bleeding on the anterior bones. Anterior bleed, right where I told you there's no bone. But that bleeding only works, or that bleeding control only works if the pressure is on the squeezy, fleshy bit and not on the bone. Why do I say that? Well, because almost every patient I see in the emergency department who comes in with a nosebleed, they come in holding pressure over the bone, and for some strange reason, it isn't working. The other key thing for that pressure to work is it has to be hard and it has to be persistent. Squeeze the crap out of it and hold it for at least 10 minutes, longer even for those older patients on blood thinners, specifically the ones most likely to call 911. Now that is where mechanical clamps can really help. All right, so here's the way to treat the nosebleeds. First, get all of your goodies together first, because you got to do this in quick order to maximize the chances of it working. Now, where you're getting your stuff together, grab some cotton balls or 2x2 gauze, put them in the little pill cups that we're putting into nosebleed kits, and then saturate those suckers with TXA. Just draw up the entire vial of TXA, squirt it into the cup, soak it all up in the cotton balls. And now you're ready to go. First, I want you to have the patient blow their nose, and I mean really honk on that sucker. You want to get all of the clots out first because you want the TXA and the other drug to get in there and be able to get as close to the vessel as it can. So blow the bejeebers out of the nose. Then 2 quick squirts, sprays, sporks, squirt. Get some Afrin or oxymetazoline. That's also going to be in the kits. Squirt that up into the bleeding nair or nares if it's on both sides. This is a vasoconstrictor, and it helps decrease the bleeding by decreasing the size of the vessel. It does the same thing, well, for bleeding anyway, that cocaine does, and I promise you, Afrin has a lot less paperwork. Seriously, we used to use cocaine in the ER for this. Now, right after, and by we, I don't mean me, of course, other people.
I do cocaine!
Now, right after you've done that, so you blow the nose, you squirt, then once the clots are out, once the vasoconstrictor is on, then go ahead and put the cotton balls in, and you want to put them where the bleeding is. Remember, most bleeding is right inside the nose, so you don't have to shove these things very far in. You definitely want to be able to see it when you're done, so just right in there. Right about where you people, not me of course, but you people, put your finger to pick your nose. That's where you're putting the cotton ball. And speaking of which, let's just face it, we all pick our nose, and that's the reason most nosebleeds happen. It's not because of your blood pressure, it's because you picked your nose. All right, finally, you got the clots out, you put the squirty stuff in, you put the cotton balls in. Now you got to apply a nose clamp to hold pressure, because I promise you, patients just cannot do this. They let the pressure go in like 2 minutes, or they press on the bone. So remember, persistent pressure on, not on the bony bits, but on the squishy soft bits. Now from there, you just leave everything alone and take them to the hospital. All right, that is it for Hemorrhage Control. Thank you for watching, and as always, thank you for what you do every day to serve our community. Take care, y'all.